This is a presentation about isoflurane, a potent volatile agent. The information has been compiled by Captain Thorben Pearson, Captain Gordon Falvey, and Captain John Moser. Name: Isoflurane. This is the generic formulation and the common name of the drug. The formulation concentration in the vial is 99.9% isoflurane per ml. The vial comes in either 100 ml or 250 ml. Forane. This is the trade name of isoflurane. The formulation and concentration of forane is 99.9% per ml as well, and comes in 100 ml and 250 ml vials. Mechanisms of action. Isoflurane is a typical halogenated ether with addition of chlorine and fluorine. Isoflurane is a clear, non-flammable liquid at room temperature and has a high degree of pungency. This is the most potent of the volatile anesthetics in clinical use. This volatile agent causes a state of unconsciousness and amnesia. Achievement of a brain concentration of isoflurane necessary to provide an adequate depth of anesthesia requires transfer of the anesthetic from the alveoli to the blood and from the blood to the brain. This is accomplished as the CNS takes in the anesthetic gas according to the tissue solubility. As an appropriate tissue concentration is obtained, unconsciousness and anesthesia are achieved. Increasing CNS tissue concentrations causes progressively deeper stages of anesthesia. Isoflurane's partial pressure values are as follows. The distribution of isoflurane in the different compartments is mainly due to its solubility. The relative solubility of isoflurane in air, blood, and tissues are expressed as partition coefficients. This is a ratio of the gas in each of two phases at equilibrium. The actual mechanism of action of isoflurane and the other volatile anesthetic gases is as of yet not fully understood. The main theories considered right now are as follows. The unitary hypothesis. A common mechanism exists among anesthetics. The Meyer-Overton hypothesis. Potency is proportional to lipid solubility. The more lipid soluble the agent, the more potent the agent. Membrane lipid theory. Anesthetics dissolve into cell membranes and produce common structural permutation, resulting in depressed function of ion channels and receptors that are involved in brain functions. The 5 angstrom theory. Inhaled anesthetics may produce immobility by concurrent actions on two sites separated by 5 angstroms, which happens to be the pore size on a GABA receptor. Receptor binding or protein theory. Anesthetics directly interact and bind with membrane proteins such as ion channels and receptors that are involved in depressing brain functions. Oxygen pathway permutation hypothesis. General anesthetics perturb oxygen pathways in both membranes and oxygen-utilizing proteins such that its availabilities to the sites of oxygen utilization are reduced, which in turn triggers cascading cellular responses through oxygen sensing mechanisms, resulting in general anesthesia, a hibernation state. Neurotransmitters. Anesthetics hinder the release of or alter the effect of neurotransmitters. The transfer of isoflurane from the alveoli to the blood and tissues is determined by 3 factors analogous to systemic uptake: tissue solubility of the agent, tissue blood partition coefficient, tissue blood flow, and the difference in partial pressure between arterial blood and the tissues. For distribution, the vessel-rich group receives 75% of cardiac output and represents 10% of the body mass. The muscle group receives 19% of the cardiac output and represents 50% of the body mass. And fat group receives 6% of the cardiac output and represents 20% of body mass. When equilibrium has been achieved, we will end up with an FA-FI of 1. Isoflurane dosing is calculated using a concept called MAC, minimum alveolar concentration. This is the alveolar partial pressure at which 50% of the population will not move to a stimulus. Every gas has its own inherent MAC value, which is calculated as a percentage. Isoflurane's MAC value is 1.15%. MAC values are additive and can be used with other gases, such as nitrous oxide. For maintenance, 1 to 2.5% with nitrous oxide, 1.5 to 3.5% without nitrous oxide. Patient conditions which lower MAC: hypothermia, geriatric patients, pregnancy, metabolic acidosis, acute alcohol use, additive effect of other medications. Patient conditions which increase MAC: hyperthermia, pediatric patients, chronic alcohol use, and chronic abuse of drugs and other medications. Onset. Onset will be roughly 7 to 10 minutes. Pungent odor limits inhalation rate. Onset is directly proportional to flow rates. Onset is inversely related to the solubility of the agent. The greater the solubility, the longer the onset. Solubility is inversely proportional to MAC values. Isoflurane's MAC value is 1.15%. The peak concentration will coincide with the onset of roughly 7 to 10 minutes. Duration and emergence time will depend upon blood concentration when discontinued. As soon as saturation has taken place and a FA-FI value of 1 obtained, an anesthetic state will be maintained. Emergence will depend upon discontinuation of the agent and adequate alveolar ventilation. Metabolism. There will be a minimal hepatic metabolism, less than 0.2%. Isoflurane will be mainly excreted as an unmetabolized exhaled gas. The decrease in alveolar partial pressure of isoflurane is mainly determined by the alveolar ventilation, solubility, and cardiac output. As seen on this graph, time needed for a 50% decrease in anesthetic concentration is roughly 5 minutes and does not increase significantly with an increase in operative duration. However, time needed for an 80% decrease in isoflurane concentration will increase compared to other agents due to solubility. Finally, time needed for a 90% decrease in isoflurane concentration will increase even further compared to other agents to the solubility. Anesthetic indications indicated for the induction and maintenance of general anesthesia. Anesthetic contraindications: hypersensitivity to isoflurane or any component of the formulation, known or suspected genetic susceptibility to malignant hyperthermia. Brief controversy concerning the use of isoflurane in patients with coronary disease because of the possibility of coronary steal arising from the potent effects of isoflurane on coronary vasodilation. This has been at most very rare in clinical use. There are also concerns that isoflurane may cause significant hypotension, hyperglycemia, hyperkalemia, nausea and vomiting, respiratory irritation, and malignant hyperthermia. Summary: isoflurane is indicated for the induction and maintenance of general anesthesia. It is the most potent of the volatile anesthetics in clinical use. And isoflurane's MAC value is 1.15%. It is mainly excreted as an unmetabolized exhaled gas, and there is a possibility of coronary steal. Here is one valuable link for isoflurane. And here are the references used for this presentation. Thank you very much for your time.